Good afternoon, everyone, and welcome to one and all. Vision 2020 India in technical collaboration with OCI and in association with Cybersite Orbis is conducting a series of webinar on different optometry topics. This is our third session in the series and it's on low vision now. So low vision refers to vision loss that cannot be corrected by medical or surgical treatments or conventional eyeglasses. So a person with the low vision must learn to adjust to it or take a help of an optometrist in using different devices and make best use of their residual vision. So today we are going to see how the assessment is done in low vision patients. And to give this talk, I would like to invite Dr. Deepak Bagga. He did his diploma in refraction and optometry from UP State Medical Faculty, Lucknow in 1998. This was followed by a 2-year fellowship in optometry from LVPI, Hyderabad. He then completed his master's in business administration with specialization operations management from the Indira Gandhi National Open University, New Delhi. He received his PhD from School of Optometry and Vision Sciences, University of New South Wales, Sydney, Australia. Deepak sir started his career as an optometrist at Dr. Shroff Charity Eye Hospital in New Delhi, and he worked there for 7 years. He was responsible to provide low vision services, administration of community outreach projects, and academics. He was one of the team leaders for a multicentric national survey rapid assessment of avoidable blindness conducted by the Ministry of Health and Family Welfare, and project manager for the Orbis supported project controlling refractive errors in Delhi. Since 2007, he has been associated with LVPI Hyderabad as a consultant optometrist. His clinical area of interest is management of patients with low vision. Welcome, sir. Joining him in panel, we have Ms. Jeenal Zaveri. She is a Bachelor's of Optometry, Master's and faculty with 16 plus years of clinical, hospital, core academic and retail experience in optometry. She currently runs her private practice in Mumbai named as Personalized Optometry and Eyewear, where she gets a good number of low vision patient referrals. She is also a visiting faculty at Lotus College of Optometry and a Rosque co-educator and a consultant optometrist with Fortis Hospital. Welcome, Ms. Jeenal. We also have Ms. Ramya S. with us today in panel. She is working as a senior optometrist at Sankara Netralaya Medical Research Foundation, Chennai, and associate professor at Elite School of Optometry, Chennai. She has completed her undergraduate and postgraduate degrees at Elite School of Optometry, affiliated to BITS Pilani, Rajasthan. Apart from routine optometric examination, she has years of experience in low vision care clinic. So welcome, Ms. Ramya and Ms. Jeenal. Now, without wasting much time, I would invite Deepak sir for his talk on assessment in low vision patients. Welcome again, sir. Over to you now.
Thanks, Harshada, for kind introduction and then arranging these series of lectures. So today what we are going to discuss is about low vision assessment. So just to understand, before we get into the topic, I would like to declare that I have no conflict of interest in relation to any of the product which is shown as part of the assessment tool in this presentation. We created a clinical pulp, but before we go to the clinical pulp, this functional definition, which most of you are probably familiar with, WHO gave in 1992 about what is considered low vision. Most of the people are familiar with this, that yes. So that is why that answer that was coming, that best corrected visual acuity in the better eye of visual acuity less than 6/18 to light perception. So there is a range up to light perception, or a visual field less than 10 degrees from the point of fixation, but who uses or is potentially able to use vision for planning and or execution of a task. So people often consider this as the referral criteria, but what they do not focus on is this asterisk here. So what is the condition applied here? So this definition is only for reporting purpose, and it should not be used to decide eligibility to avail rehabilitation services. So that is so important. So when this document consensus was there, they had very clearly mentioned this is for the reporting purpose. So when you're reporting that the persons whom you provided services or whom you are catering to, how many people are into the category of low vision, how many people are into the category of blindness, how many people are into the category of normal vision. But it should not be restricting the person to avail rehabilitation services, which means there may be people who may not fit into the definition, but may still require low vision rehabilitation services. So that is why this clinical pearl is there. So when you have such dilemma, just don't restrict yourself by looking at the best corrected visual acuity for distance or near or visual field, because there may be people having impaired contrast sensitivity. People may have uh, color vision related issues. There may be functional issues because of the uh, other visual functions which are impaired. So what you should remember is, if a person is not happy with his or her best corrected visual acuity to do their day-to-day activities, she or he is candidate who needs referral to low vision clinic. So it's more of functional based referral. So there might be people with 6/9 acuity, 6/12 acuity, or 20/40, 20/30, and they may still require your services. So it's important to identify people based on the functional needs and then refer them. So in the next 30 minutes or so, what we are going to focus on is the impact of vision impairment on individuals' participation in daily life, application of ICF framework in low vision assessment, and steps that are involved in low vision assessment. If you look at this animation, which is provided by one of the person with visual impairment, she has Stargardt disease, Dr. Erika Tanduri. So it's courtesy her, she was kind enough to allow me to use this animation here in the presentation. So when person with Stargardt is trying to focus on chopping tomatoes, see the challenge which she has. She's not able to see where she's trying to focus. So it may be as simple as day-to-day chores like this, or reading small print, writing, or somebody with advanced field loss may have problem with mobility or driving at night time. So these functional areas may get affected, and because of restricted mobility, or if the safety is compromised, they may restrict themselves to attend social events. Social participation may be impacted. And when they come to clinician and they get to hear there's no treatment for it, there's no intervention for it, and nothing more can be done, it affects their mental health, their emotional well-being, their psychological status. And adjustment to vision loss becomes difficult because there's no treatment possible, and there's no ways, nobody's trying to refer them to rehabilitation. And it impacts their overall quality of life. And that is what vision rehabilitation tries to focus on. So this is what the list of uh, objectives or the purpose of low vision rehabilitation that have been listed by Vision Rehabilitation Preferred Practice Pattern by American Academy of Ophthalmology. If you look at their article, so you'll find that, yes, so where you are focusing on is maximizing access to printed material, improving the ability to accomplish day-to-day functional tasks, improving their safety, optimizing social participation, addressing the impact on psychological status and overall quality of life. And how do we achieve that? To understand that, what is important is to look at the ICF framework. So like, so WHO has given this international classification of functioning, disability, and health that can be applied across any health condition to understand how it impacts the functioning of an individual. You can look at the first area here is at the organ level impact. So say if we take example of macular dystrophy, where is it affecting at the organ level? It might impact the central acuity, distance visual acuity, near visual acuity, contrast sensitivity. You may find central scotoma in the visual field. So those are only at the structure level which you are seeing. So in the clinic, routine clinic, what people focus on only at the structural changes. They do the look at the macular thickness change, the structural change or functional change at the photoreceptors level. But how does it impact the person's functioning and day-to-day life is something which is the focus of your rehabilitation. So when person comes for low vision assessment, what we focus on, how does it impact the individual? So at individual level, does it impact person's reading ability? Does it impact person's ability to locate ball when they are playing, identifying their team members? And if those are things that are affected, how does it impact in the larger perspective when they're interacting with their environment, when they're participating in games? So if that gets affected because of these restrictions in functioning, that is called participation restriction. So say somebody with macular dystrophy having those challenges in games is excluded from the team. That itself has participation restriction. Okay, so but when you see in the clinic, you may find there are two kids having or two children having different level of participation or different level of involvement in their day-to-day activities, despite having similar ocular conditions, similar visual acuity, similar contrast sensitivity, similar color vision deficiency. So if the structural functional measurements that you are doing at the clinic are similar, but you find their participation levels are different, what could influence those areas, because your ultimate goal is improving participation. So you need to understand what could be the non-visual reasons that can also influence the person's involvement in day-to-day life. And these could be at the personal level, the intrinsic motivation of the individual. So some people may like getting involved in the games, or they may not like it. Similarly, some people may like continuing their education, some people may not. So there may be personal preferences, level of enjoyment, and then personal self-esteem may also be an important component. So when people are bullied and other things, which may be an external factor, that how they're receiving the support, but how does the person receives it or perceives it is a personal factor. So there are factors which are at personal level, which might influence the person's involvement, and there are external factors like support from the teacher in the classroom, support from the peers, support from the family members, their encouragement, their attitudinal thing, including the role of assistive devices or adaptive materials and their availability. These are all factors that might influence the person's involvement in day-to-day life. So this model includes not only the medical perspective, but also the social perspective. And that is why it's considered so important to understand this mechanism when you're doing the holistic evaluation for persons with visual impairment. So keep this in mind, that it is not only at the structure level we are measuring, we are looking at the functional level in different aspects. And we are also trying to understand how the environment and the personal factors interact with the overall participation of the individual, because that is the ultimate goal of your low vision rehabilitation. The other important point that you should notice here, so here in this graph, with what you're seeing is on the here you're seeing the age categories on x-axis, and y-axis you're seeing the percentage of patients, and you are seeing that 9 different domains that are plotted here of persons functioning. So herein the researchers, authors have looked at that the functional problems that were reported by the parents, how it has changed over a period of time. So if you look at the mobility, one of the aspects shown with this triangle here, see this mobility aspect, wherein almost 40% of the patients are expected to perform that at the age of when they're around 13 or above. But if you look at when they're around 0 to 2, parents are not keeping that as the priority. Similarly, if you see the domestic life here, which is say shopping, doing daily chores, taking care of pets. So when kids are around 7, 8, parents may not expect them to do it. But when they are around 13 or so, parents would expect them to perform those tasks. So those things may reflect in your rehabilitation goals. So this change in the rehabilitation goal over a period of time, depending on at what life stage you are, which means there's a continuous follow-up or regular follow-up which is required to see how the rehabilitation goals are changing, even if a person is having a stable ocular condition, stable visual status, because the rehabilitation goals may change over a period of time. It is important for us to assess and suggest those whatever are the strategies required for them to function equivalent to their peers or healthy peers. And if you think about what contextual factors, so this is in-house research wherein we looked at in children with low vision or blindness, what are the different factors which may promote their participation and things that may be restrictive. So things which promote their participation are considered facilitators, and things which are negatively impacting their participations are considered barriers. So if you see some of the examples, a child's interest can facilitate. Societal things, if they get support, maybe facilitator. Product and technology is basically the assistive devices, maybe so these are perceived facilitator by children with low vision. But if you see the parents, neither barrier nor facilitator, the same low vision devices. So here, if it is coming somewhere here, which means equal number of participants, because this is the average of close to 100 participants response. So which means similar number of parents would have said that it's useful. Some similar parents would have said that it is not useful because people are bullying, and then it doesn't make much sense. Rather, if there's medical treatment, so they would have not considered it as one of the facilitator. Rather, they would have considered it as a barrier, the use of low vision devices. Bullying, certainly, if you see, there's a consensus, bullying, child's feeling and light levels in the workplace or in the school may impact the negatively. So these are considered barriers. So understanding this holistically is so important in your functional history. And what are the steps that we consider when you're doing the low vision assessment? So these are the 6 broad steps. First one is, before you invite or call the patient for evaluation, go through their medical record, whatever is available with you, because that may give you the starting point, may give you the cause of low vision. That itself may be indicative that there is a stable condition, like in patients with albinism, cone dystrophy. You know that these are stable condition and since birth. So the duration of vision loss, other things also will get. In patients with, say, diabetic retinopathy, glaucoma, there are certain things which are acquired. You get it later. So what is the duration of vision loss? What is the level of impairment? And because those are the things which are important for us to understand whether, if it is longer than 6 months or a year, person would have probably made some adaptation. But if it is a recent onset, person may still be seeking for the medical treatment and may not be prepared for low vision rehabilitation. The second component of your low vision assessment is observation. So if you see here, you have gone to call a patient, you see like this. So, looking at the face itself, that yes, person is having albinism, is having photophobia. So there are certain things by observation itself you can make out. People with the advanced field loss, if they have problem with mobility, you can make out those things when you are escorting them from waiting lounge to your examination room. So this is so important, and this observation continues till you complete your examination. So when you're doing the assessment, you may find people having nystagmus, people having eccentric viewing. So you should encourage them to do that. And determining visual objectives. So that is done using a structured questionnaire. We will look into each component of this. In the clinical examination, you consider these 6 visual functions you try to assess. We will focus on the first 4 during this presentation. Calculation of magnification, we'll briefly look into. Trial of assistive devices. So I think the next presentation is about assistive devices. So we will leave the assistive devices for today's presentation. We'll not cover that. So as for assessment of functional needs, because you looked at that there are 9 broad domains in the participation that are part of the ICF framework. Now, it's difficult for you to remember. So it's always good to have a structured questionnaire, functional questionnaire, so that you have ensured that you have comprehensively assessed their functional needs. So for school-going children, we have developed in-house LV Prasad functional vision questionnaire, which has 23 questions. And you can see some of the questions which are listed there, which can help us understand that what child's functional needs are. Similarly, for classroom environment, it is so important to understand what kind of color of chalkboard, because the contrast related, because this will also indicate what kind of suggestions you have to give. So say if child is sitting at 6-meter distance from the board, and by moving at the front bench, which is usually about, say, 2.2 meter, you have brought the person 3 times closer, you will get 3 times magnification without using any devices. So those simple adaptations can be suggested to the individual. And this paper from Shankar Netrale, which suggests that the visual acuity, average visual acuity demand for person sitting in the front row is 20/72. And the standard distance that is recommended is 2.2 meter, but that was not maintained in 82% of the schools, government schools, where they did the study to look at that what proportion of schools maintain that recommended standard distance. So if the distance is more than 2.2 meter, it's 3 meter or 4 meter, certainly for the person with mild impairment, it may have implication. They will have more functional problems. And the simple solution that you can recommend is move the chairs a little bit closer. So, or keep it at the standard distance. So this relative distance magnification or approach magnification alone may be a suggestion for person. So we call it a simple approach to magnification or relative distance magnification. This is a simple thing which you can recommend without thinking about assistive devices. And people, if they can manage sitting in front row, you may not need to think about any magnifier or telescope. If that is not sufficient, person still has problem, you may calculate magnification that is required for distance. A simple formula can be used. You can use the denominator of best corrected distance visual acuity by denominator of target visual acuity. How do we get the target visual acuity? Now we have looked at what is the visual acuity demand here, 20 by 72. So if you say you're keeping 2 lines reserve, acuity reserve, and the average acuity demand is 2040. So this is there based on the evidence. So you keep 2040 as the target. So 40 you're keeping as a denominator here for calculating. You get 4 times magnification. So you know which telescope has to be tried to get the result. Similarly, for reading related requirement, you have to be very specific to know what exactly they want to read. If they can bring their reading material for the assessment, it will be nice so that you can verify using those magnifiers if they're able to manage reading, because each reading material will have different specific print size. When you're doing distance visual acuity assessment, at times standard test distance may not work of 6 meters. You may need to bring it at 1 meter to do it. And similarly, if at 1 meter it doesn't work, you may bring it at half meter rather than doing counting fingers. So don't do counting fingers, because that is not a scientific or a standard method that will not help you to calculate magnification. Encourage patient to use eccentricing, use appropriate test chart. So a person cannot respond to the letter chart, you may use Lear symbols or any other appropriate test chart so to quantify visual acuity. And if person is unable to make out the largest optotype even at half meter, you may think of using Berkeley rudimentary vision test. So here, and if you see these 3 cards which are provided, single tumbling E at 25 centimeter may enable you to record acuity as low as 20 by 8000, which is 2.6 logmar. And this is developed by Ian Bailey. He's demonstrating in one of the workshop how to make use of it. And then if person is not able to read the largest optotype, which is of 100 m size at 25 centimeter, then you record with the grating acuity cards. And then if a person fails to identify or recognize the largest grating direction is itself, then you go for the basic vision card pair, wherein person has to identify which hemi field or which direction or where is the white field projected here. So white field projections, that's why it's called white field projection target. And here in person has to identify which side is, whether it's a black card or it's white. So black and white discrimination targets here. So this will enable you to quantify visual acuity as low as 3.5 logmar. So there are papers wherein people have criticized that this grating acuity should not be converted into Snellen fraction. We understand those things are there, but for the clinician to understand and to compare, yes, people still in the convention, they convert into Snellen fraction, and logmar values is grating acuity rather than writing as the way it has to be. And the second important component here, when you're doing the visual acuity assessment, what we are keen to look at is, as you have looked at in the definition also, we are concerned about best corrected acuity, not the presenting acuity. Because in large proportion of patients, you may find that best corrected visual acuity itself may improve the functioning of the person. And what special consideration can be done when you're doing refraction? You can use large fixation target for person to fixate at, and adjustable trial frame and wide aperture loose lenses might be useful. Wide aperture loose lenses, which you use for visual field testing, those may be useful rather than using smaller aperture, especially in patients who are having large eccentric viewing. At times, it may be difficult for them to perform, for you to perform the diffraction in those cases. And if you're not able to see visualize the reflex at your arm's length at 60 centimeter, come at say 20 centimeter or 30 centimeter, reduce the test distance, come at 20 centimeter or 15 centimeter, and then try to visualize the reflex, and use different estimation techniques to identify what is the refraction value. And similarly, over refraction, if somebody is having very high refractive error, may help you perform objective refraction. In subjective refraction, non-standard test distance, which you have used for recording the visual acuity. If you have recorded 1 meter or half meter, you can start subjective refraction from there. And as the acuity improves, you may probably increase the test distance. And the other concept which is used for applying bracketing technique is called just noticeable difference. So this is the minimum dioptric difference that a person can differentiate. So how do you calculate the minimum dioptric difference that person can differentiate? So say if someone is having acuity of 20 by 200, herein the denominator 200 by 100 gives you the noticeable difference of 2 diopter. Herein at this level of acuity, if I make change in 0.5 diopter or 0.75 diopter steps, person may not be able to respond for subjective refraction. But if it is large enough differences, which I'm demonstrating, which is larger than 2 diopter, which is the person's noticeable difference, person can appreciate the difference and respond to it. This concept can be applied in multiple places. This can be applied even when you have the refraction value. If you have got some refraction value when you're doing subjective refraction, so when you're comparing two lenses and you're trying to see how the acuity improves or which direction I have to change the lenses, this concept can be used to do the bracketing technique. Bracket means one will be lower limit, one is upper limit. So say somebody is having acuity of 20 with 200 with the correction in place, and you want to refine it further. So you use half of it, which means +1 and -1. So which means the difference between the two is 2 diopter. You keep over their refractive correction value and see which direction person is saying is better. If person's refraction value was +10, when you add +1, it becomes 11. When you add -1, it becomes +9. So you're comparing between 9 and 11, which is better. And if person says 11 is better, now say acuity improves from 2200 to 2160 or 2125, 2000. So you see that the incremental change which is there, and what will be the next your noticeable difference. Based on that, you create next bracket size, and then you continue till person says either side it is equally blur or equally clear. Midpoint of that is your endpoint of subjective refraction. So that is how you apply the concept of just noticeable difference and bracketing technique to refine in patients with low vision. And in some cases where you don't have any starting point, say, and you have got person having severe visual impairment, say person having acuity of 20 by 1200, 12 diopter is a noticeable difference. You can start with ±6 in the second example, which is shown here. So this is a case example. Person came with adherent glaucoma. You can see in the center, and it was recorded that dull glow, poor glow, no improvement to the refractive correction. So herein we looked at that if from the upper portion of the pupil or here from the cornea, can somebody peep in, can somebody do the refraction of phakic, so and get some values. Because if I look at the presenting acuity, this person falls into the category of WHO's definition. If you follow standard definition, it will fall into the category of blindness. But if you consider with the refractive correction in place, you see he falls into the category of low vision. So acuity has improved with the refractive correction. So you can use, if even if you didn't get any refraction, any glow, you can do the just noticeable difference concept bracketing technique, get the spherical endpoint. Then you can use the stenopic slit to or astigmatic fan to find out the amount of cylinder. So those things can help you. So apply the theory that you have learned about objective subjective refraction in these patients and see how things change, how things improve or with the evaluation. And there are literature which suggests that improvement of 2 lines or more, which is significant because 1 line difference is considered test retest variability, and is observed in these patients with low vision who were referred for assessment in 11 to 27% of the cases. So this improvement from profound to mild impairment in some cases, and it happens across the diagnosis. It is not very specific that it's only for the corneal condition or for retinal condition. At times high refractive errors are missed, or an isometropia may find which has not been corrected, and correcting those appropriately with appropriate methods may improve the person's functioning. So that should be the first approach when you're doing the low vision assessment. The next important component is the near visual acuity. How do we determine the working distance? So often I get to listen from students saying that we give it patients comfortable distance or their habitual working distance. But then when you say best corrected near acuity, then that has to be corrected appropriately. So you have to think about what is the amplitude of accommodation. Does the person has adequate amplitude of accommodation to focus at the distance where I'm recording near acuity? So if I'm recording near acuity at 25 centimeter or 30 centimeter, does person's amplitude of accommodation, the amount of addition given, and if person is undercorrected myope or undercorrected hypermetrope, what will be the implication there, may influence the working distance. So these three factors needs to be considered when you are determining the test distance for recording the best corrected near visual acuity. If you get this concept right, then the best corrected near visual acuity, if you feed in to calculate your near magnification, you may not need to do the trial and error method, which most of the practitioners say that low vision devices prescription is all trial and error method. It's not. So then calculation doesn't make sense. It doesn't make sense because most often best corrected visual acuity is not recorded. You have given 3 addition to a person who's aphakic, and rather than recording at 33 centimeter, if you are recording at 15 centimeter or 10 centimeter, which because that is the habitual distance of the person, then you do not get the best corrected near visual acuity because person's optical system has not been able to focus there clearly, and that is not going to fetch you the right magnification that is required. Yes, in some cases, a couple of centimeter change may be okay because of their depth of focus, may influence the range. The other important component is to look at the response to illumination. If person with additional illumination improves by another couple of lines or so, then you have to consider illuminated magnifier. If you're considering magnification devices, then whether to consider non-illuminated or illuminated magnifier, this is one of the criteria which influences looking at the response to illumination, especially patient with glaucoma, RP, retinitis pigmentosa, patient with age-related macular degeneration. This may be so important to look at the response to illumination. And for the near, like we are discussing about the addition, it is not only for the presbyopic age group, but in fact, in patients with pre-presbyopia as well, addition may help. And there are papers and work done by Susan Leet in their paper wherein they have looked even in the children with visual impairment, because these children or pre-presbyope patients do not maintain standard working distance of 40 centimeter. They tend to read at 15 centimeter, 10 centimeters. So when somebody is trying to read at shorter distance, which means they are trying to get relative distance magnification, there, if there's a having significant lag of accommodation, then it may help them to give addition glasses and to see if the addition prescribed in spectacles help them improve their reading performance. So 86% of the pre-presbyop, however, they had small sample size, but they reported that they had poor accommodative response when it was recorded at shorter test distance. If that does not help, even giving the addition, appropriate correction does not help to reach the match the person's requirement. If person wants to read N8 print, N6 print, you're not able to do it, then you have to think about magnification calculation for the near. Therein, what is important is to keep in mind the minimum acuity reserve concept. So Jan Lovey Kitchen's work suggests that the 3 lines acuity reserve is important. So for simplicity, what you can remember is if somebody wants to read N8 print in newspaper, you can make it half of it, N4 as a target. So when you're calculating magnification, keep N4 as your target. You'll get the right equivalent viewing power to calculate the magnification. So here in what you are seeing is 1:2 ratio for fluent reading. But another recent paper wherein they looked at the comfortable print size that can be used as good estimate for magnification calculation. And what this found in their paper and in their work was that comfortable print size was consistently smaller than twice the reading acuity, mean difference of 0.11 logmar. So here in the acuity reserve, with average acuity reserve of 1.74. So 1.74 or 2, if you keep, I think both should work. So usually in our practice, we keep 2:1. That is what we keep as the ratio to start with. So which means if somebody is having, say, best corrected near visual acuity of N20 at 25 centimeter, and you corrected them with the 4 addition, or they have amplitude of accommodation to focus at 25 centimeter, then if you put this information in this formula to read N8 print, or you'll keep the target of N4. So your EVP will come 20 diopter. But if you increase the target, say for somebody wants to read large print book and 16 font size, then your EVP will become half. So it is so important to know that what print size person wants to read, so that you can manipulate or you can change your target near visual acuity. Best corrected near visual acuity and test distance has to be carefully recorded. And then when you put that in the formula, you'll get the right equivalent viewing power. And then that information guides you that, okay, if equivalent viewing power is 20 diopter, whether I use 20 diopter spectacle magnifier, 20 diopter hand magnifier, 20 diopter stand magnifier, illuminated, non-illuminated, those are the things which you have to consider. And then based on the task requirement. So there are multiple other factors that you have to think about. But before you jump into the assistive devices, you can also think how has the patient been managing so far, if person is having this for problem for 6 months or 1 year. And these days many patients say that I use mobile camera and magnify. So if they are using already, if they are happy with it, I show them this vZoom app, which is there in Android phone, can be suffice for their functional need. The other important thing which is there is contrast sensitivity that you need to assess. So if you have palette option chart, some clinicians, if considering the cost, if they want to use 10% low contrast visual acuity charts, which are bit economical. Herein, what is observed is you compare it with the high contrast visual acuity. So say high contrast acuity is 6/18 or 6/12. How many lines difference you are seeing in the low contrast visual acuity? And it is considered that up to 3 lines difference is considered normal. 3 lines drop in the 10% low contrast visual acuity. But if it is more than 3 lines difference which you are seeing, it's considered significant contrast loss. And you will see a large proportion of patients, 30 to 40% of the patients that come to low vision clinic may complain of glare. So for them, subjectively, you can do the assessment. You can take them outdoors, try with different filters. And the way you select the filters is for most of the posterior segment pathology, say patient having RP, rod monochromatism, cone dystrophy, usually the red orange filters might, or the amber orange filters might work, those colored filters. Whereas anterior segment pathology, say persons having corneal dystrophy, Stevens-Johnson syndrome, usually the neutral density filters like gray, amber may be more preferred, because these yellow, orange color, which enhances the contrast, but may impact their perceived colors. So that's why they may not prefer it. So at the end of trial in the outdoors, what do you want to see? You want to see this smiling face. You see that wow factor, that yes, person, the moment they feel that yes, they're not squeezing their lids, they are able to keep their head straight, they're able to walk around, they perceive that there's a obstacle detection becomes easy because of the improved contrast. So those are things which you assess and then decide which filter has to go, whether it has to go fit over the prescription, or it has to be incorporated into their prescription. And these are multiple factors that can be considered for task specific, patient specific, or device related factors that can be considered when you're deciding which assistive devices have to be suggested, in addition to the magnification calculation. This is a simple case of 8-year-old girl studying in class 3, having heredomacular degeneration. Best corrected visual acuity is 20/160, and near vision is N5, and her major complaint is copying from blackboard. Parents are concerned about her maintaining short working distance for watching TV and reading at short distance. So if you see the simple solution, if you calculate magnification, you'll get 4 times magnification because her acuity is 20/160. And with 4x monocular handheld telescope, you achieve the target 20/40. She's able to manage the classroom work, and you just dispel the myth related to short working distance. You say it's all safe. She can maintain shorter working distance. It's not harmful as far as she has ample of accommodation to manage that. So the strategies to achieve low vision rehabilitation goals include dispelling the myths related to short working distances, maximizing the use of residual vision by providing refractive correction, magnification, scanning, and eccentric viewing. Some environmental modification, like we discussed about role of illumination, contrast, those are important. And in patients with severe visual impairment, at times magnification devices may not work, so you may need to consider sensory substitution devices. So various assistive devices will be covered in the next topic. I'm happy to take now questions if there are any.
Okay, my first question to Deepak sir is, how to encourage private practitioners to start their own low vision practices at their clinic.
It is, I think, the interest, and anybody who claims that I'm providing comprehensive or total care, it is not total if you are not providing rehabilitation or low vision services. So that has, and then the other thing, private practitioner often, if they think that it is expensive, so I have shown you the examples wherein without assistive devices, also just providing addition can help the person. So you can many solutions you can offer without providing assistive devices. So it's not expensive. It is most of the common sense approach, certain basic principles. And yes, once you provide care, complete care to the person, you may get their family members and other people also coming to you because you have offered something which nobody else has done it. So these case examples, once you keep forward, I think that will encourage them. I'll request others also to add if they have some other ideas too. Ramya, Jinal.
Yeah.
Can I?
Yeah.
Yeah, sure.
So see, I am a private practitioner in Mumbai. I have also been in LV Prasad, for 2-3 months during my internship. And the low vision, what they practice is intense and complete. I mean, nothing can beat the LV Prasad low vision department. But having trained under Dr. Vijaya Kumari and Lotus College, at least I've realized one thing, that whatever little difference you make in a low vision patient's life is going to change his complete personal life, social life, and the economic life. So nothing is something which you have to have a complete package. You can do in whatever small ways. You can start small with a small kit with you, in terms of your devices. You can have a little network with your local neurologist, diabetologist, retinal specialist, and of course, ophthalmologist, where you can tell them that I'll be able to give them primary low vision care, including rehabilitation. Because if rehab is skipped, it's not over, as Dr. Deepak rightly said, So just a set of spectacle magnifiers to your filters, a simple filter for an albino patient changes the life. So those little things also, if you start changing in your private practice by spreading awareness, in terms of giving them that satisfaction of living an independent life, is something for your personal growth also and for the patient's growth also. In terms of devices, yes, a little investment. Charts, you can just start with a little of logma for distance and your reading chart. You don't need anything high end beyond your regular refraction to start with, at least, because you will be able to at least calculate your magnification required with your reading chart, your distance logma chart. You cannot do it on a Snellen chart for sure. So even if it's not a complete digital chart and all that, a 3-meter regular logma chart is good for you to start in your practice. Have a set of telescope, basic 4x, 6x. It will work to start your evaluation. I generally connect with a tertiary low vision center also, where if I need a digital equipment, I do a phone history with the patient initially. And then I will understand what are the basic things needed for that patient, So if it's beyond my capacity in my practice, I approach the institute, I procure the devices prior, and then I try and do the trials. So you may not want to invest initially for everything, but starting small will also make a huge difference. So start with your small kit, do your network. Again, spread awareness from your side, because most of the patients who come to me are like, oh, I never knew something like this exists. At the same time, set very realistic expectation, because most of them come with files, like they have gone to 3-4 doctors, nothing has worked, and then they have come to you. So set realistic goals for them, what you can provide, understanding the condition, and then of course rehabilitation plays a major role, counseling, and it's a change for good.
Yeah, I also totally agree with the other two speakers because, as Sir told, just by giving an addition of 4.5 diopters will definitely improve the reading demand, and they can very well use the approach magnification. And with increased illumination, they can do their activities very nicely. And as Sir told, I have seen many smiling faces after giving just small addition glasses, just a single vision glasses along with increased illumination. And also many people will be having trouble in using smartphones. So if I just tell them that there is an option of magnification or triple tap in the app which is inbuilt in all the mobile phones, they'll be very happy to use that. And as sir told, we can also use that other apps to see the reading materials. So it's very nice to see such patients smiling faces just by adding few points, just which does not cost any much actually. As ma'am also told, we can just give some filters which will definitely help them, or we can just advise them to use a hat or an umbrella, or just use a full sleeve clothes, so that they can avoid sun exposure, especially in patients who are very sensitive to sunlight and all that. So I totally agree with the other two speakers. You don't need much investment in doing a low vision practice. That's the main important point which the attendees need to consider, that you can just need to have a small set of spectacle magnifiers, a small set of pocket magnifiers or handle magnifiers, so which will not cost much, not 100 rupees or 200 rupees. So that is going to really change the life of many patients.
Yeah, very true. Yeah, because people have this misconception that they need a lot of investments to start this clinic, but it's not true actually. Ms. Jinal, I want to come
Very
to
big.
you that,
Sorry, Harshada. Sorry, just
yeah,
one point to add over here. And there's another major issue where people feel low vision has a lot of chair time. Yes, I agree it
yeah,
has a chair time. But if you give at your busy hours, like I do all my low vision patients in the afternoon only because I want to do justice. So you can't give reasons for not doing, in short, everything is possible if you want to do it. And afternoon time, no retail practice or no private practice are going to have regular patients. So that's the time you can devote to these patients.
correct, correct, yeah. Okay, I would like to ask one more question, Ms. Jinal. How should we work on getting more referrals? Because low vision is something that we get patients from the referrals from retina specialists or from the hospitals.
Yes.
So how should one private practitioner work on that aspect?
So see, for me, when I look at referral practice, of course, ophthalmologists are your number one targets, a lot of times to tell them what are the conditions you can help and what are the conditions you can't help. Retinal specialist, of course. What another two targets I have realized, diabetologists, because a lot of diabetic patients are getting into diabetic retinopathy and they are not aware of that, a simple prismatic spectacle glass is going to change their life. So information, just a small kind of a poster being given to a diabetologist clinic, where you are collaborated with them for low vision services. Of course, collaboration with retinal specialists and ophthalmologists are given, but even occupational therapists, a lot of children who come with multiple disabilities, who are regularly with occupational therapists and they have visual issues. So I have even tied up with 2-3 occupational therapists in my area where they are aware of that, okay, low vision services are existing in this local region also. So diabetologists, occupational therapists, private hospitals, a lot of tertiary hospitals also, like I consult at Fortis as a low vision and contact lens specialist. So I only go for these two category of patients. So there are multiple range of doctors who come there. All of them know low vision is available here. The patients are lined up and you can see the patients and go. So even with your practice, you can do a locum service at a private practice of an ophthalmologist who are not willing to send their patients. Or, if they want to give a 360-degree holistic approach in their setup, it's not very difficult for you to carry few devices and go and do the counseling there also. So diabetologists, one good thing I have found is they have realized the importance of vision and diabetic retinopathy where they do refer patients. In terms of spreading awareness, it's best to do one-to-one publicity with all your regular patients also, because some or the other person in the family is surely going to have some visual issue. And if they are aware of that this kind of thing exists, so I have a little small board also in my practice where, I tell a little about low vision, what it is. And then they will be curious, oh, what is this? Some devices on display, oh, what is this? And then you can explain and then they can spread the word accordingly. Then at college level, we do a lot of train the trainer programs, where we train the educators to identify, if a child is struggling and to report to a low vision specialist if they see that they are not able to do their routine work in terms of reading, blackboard viewing with the best corrected glasses, then they are the ones also to refer. So a lot of workshops for awareness also can be done. So these are those little things, which we can progress. One more thing which I have always got a little fascination is to provide funds for low vision devices. Like we have a lot of, camps and cataract donations and everything, but people don't give donations for low vision devices. So there are poor patients who are not able to afford a lot of times, and we kind of find donors through our referral. But if there is a group, or somebody who is ready to sponsor low vision devices, also, will help us to tell patients that if you can't afford, we'll be able to provide you one. That's also one way to spread awareness.
Right. Yeah. Thank you so much. There are a lot of questions in the question and answer box for Sir, actually. Okay, we'll take one by. I think Sir has already answered 2 questions. I'll take the next one. How is the contrast sensitivity related to low vision?
Yeah.
Yeah.
Yeah, so contrast sensitivity is related to low vision because certain ocular conditions which may impact contrast sensitivity badly. So say optic atrophy. So if contrast sensitivity is impacted in the specific ocular condition, then what you may think about, in those cases, optical devices may not work. Electronic devices which enhances the contrast might be a better option to choose for. And then similarly, the suggestion on illuminated or non-illuminated magnifier, like I said, that check about the response to illumination. So we also understand that illumination at times plays a role for people having impaired contrast sensitivity, and they may prefer illuminated magnifier over the non-illuminated magnifier. So and the other thing which is important for you to understand is there are some ocular pathologies wherein the high contrast visual acuity may not impact much, but yes, that contrast sensitivity may be impacting. So their progression of disease also, you can see that if there are subtle changes wherein person is complaining that my vision is deteriorating, but in your high contrast visual acuity chart is not showing any change over there. Similarly with the treatment, if they're responding and they're finding that there's an improvement, but you may not be able to document with the high contrast chart. So it's so important to record contrast sensitivity in patients with low vision.
Thank you so much, sir. Okay, there's one question regarding the availability of the low vision trial set for private practice, where to order, or maybe
So
yeah.
So see, whenever people talk about kit, I have my own personal reservation, because whenever you put it in a kit, at times there may be 2 or 3 units which may be useful, remaining all non-useful things also the provider will add it and then supply it to you, because you do not understand how to make use of it. So first try to observe, so do the observation, either observership or training, to understand what works, what doesn't work. And once you identify, you will realize that okay, there are few devices which are very frequently used. Just start with those few devices, maybe just 4 or 5 handful devices. Lord Gina like mentioned that 4x telescope. So if you see, you may have telescope available at 2x, 3x, 4x, 5x, 6x, but 4x is 90% of the cases you may consider it, and 6x very rarely you may consider, and 2.1x you may again not prescribe that often. So certain things which goes frequently, you may start with that. Similarly in other stand magnifiers also, I may consider dome magnifier more frequently, low magnification. Similarly, spectacle magnifiers +5, +8. You may not need to have the complete range. You may start with small, see how the response is. In place of digital magnifier, you may think about the apps which are there in smartphone. If that is working, but a person has problem with adjustment, you may suggest there's a device which will be easy for you to operate. And if they are interested, you can always provide them information where they can source it from. So there are so many vendors in the country. Muralidhar Omtao is one which provides range of based in Hyderabad. You have Baliwala Homi, which provides spectacle magnifiers in Mumbai, and then digital magnifiers we are getting from Vision Aid. So they are, and then at times you may compare it, the cost price across different sources. In Hong Kong Society for the Blind, we import LED magnifiers from them, and you see what is most economical, because if your landing cost is lower, you can keep the cost lower for the end user as well.
Thank you, sir. We'll take the next one. Can we do the JND test in the log unit value also? And also the magnification calculation, can we do it in the log unit visual acuity?
Yes, it is possible.
Okay. Okay, does the LVA have some side effects on the visual acuity of customers? Yeah.
No, it's safe. I tell every patient, Even I use a magnifier to examine your eye. So our slit lamp, wherein we are using 16 times, 20 times, 24 times magnification, is a magnifier. We use illumination, we use magnifier every day, day in, day out to examine you. It's completely safe. If it was harmful, I would not use in the first place.
Okay, and okay, one more question we'll take. If you can enlighten more about the 3:1 line for N4 is equal to N2 slides, as you had explained.
I didn't get you. Which one?
Mr. Mohammed Jamil Akhtar, please, could you be, you can unmute and talk.
Okay, 3:1 line for N4. Okay. So, so herein what you're talking about acuity reserve. So say if you look at the analogy of when you're correcting presbyopia. So if someone wants to read at 25 centimeter and has 4 diopter of amplitude of accommodation, so 4 diopter should be suffice for them to focus at 25 centimeter. But for sustained reading, for prolonged reading, it may be difficult for a person to use 100% of their accommodation facility which they have. So what will happen is you'll keep 1/3 in reserve, or you'll keep half of it in reserve, and then you'll provide person 1.5 or 2 diopter of addition to keep something in reserve so that person can read effortlessly. Similarly, what is known when you're recording threshold of near visual acuity. So say if you have recorded near visual acuity of somebody as N8 at 25 centimeter, and that is the print size which they want to read. Obviously, reading at threshold means 50% accuracy with difficulty they can read it. So prolonged reading will be difficult, and there's a lot of guesswork which is going on. But if you increase from there the font size to N10, 12, 16, you will observe that their speed, reading speed and accuracy improves. So minimum print size where your reading speed is maximum is called critical print size. And usually what is observed that for fluent reading, the ratio is 2:1. And that is why if somebody wants to read N8, we keep N4 as the target. So to so they want to read N8 print, but you are bringing their threshold down to N4. So that is why that ratio is there. But there are other researchers who have found in their clinical practice that this may not be true for all the cases. Even 1.74, if you keep as the difference, which means not in place of 3 lines, 2.5 lines difference also, if you keep, should be fine. So we were calculating and seeing that it hardly makes much difference. So if you keep 2:1, simple this thing should be good to start with, because like when you're doing subjective refraction after objective values, you refine it further. Similarly, that is a good starting point in the same magnification. So if your EVP comes 20 diopter, you're starting with 20 diopter magnifier first, you're seeing the response, and then based on that you decide whether you have to think about 24 or 16. You have to go one step up or lower, and what works best. So that is again based on because 16 diopter lens will have larger diameter, larger field of view. And if you're going for 26 or 24, the field of view will be compromised. But yes, and then there'll be combination of approach which you can use it when you are giving along with the devices. So the test distance that person uses, the working distance, and along with the magnification and the print size that you're using. So often when you're combining, it is not the additive, it is the multiplicative. So those are the things which we usually apply when you are deciding about the final devices.
We'll take the last question. Which medicine should we prescribe for the low vision patients and which we shouldn't?
So there's no medicine. That is why.
Yeah.
So if it can be treated medically, patient will not come to us, and it is not in the scope of optometrist practice to prescribe any medicine.
Thank you, sir. Okay, there are 2 more. One is for fellowship in LVA. I think the criteria would be mentioned on the website. Sir, is that right? Or...
Yes. Anybody with a bachelor's in optometry or diploma in optometry, you can apply. You can send your CV to us, and we will consider. We will and we may see, talk to you, and then understand your requirement, and based on that we can customize it if it is needed. Usually 3 months fellowship which we offer, and then there's a blended training program again which has 3 months duration. 2 months is online training and 1 month is hands-on training in the LV Prasad Institute.
Okay. Okay, I think we are good to end the session. Thank you so much, sir. Thank you all. Thank you, Ms. Ramya and Ms. Jinil, for taking out your valuable time to be with us today.
Thank you.
And thank you all the participants for attending this webinar.